from an interesting paper, and this is about talking about the GnRh agonist trigger. And there are a few points which are quite interesting that come out from this paper. So the question is, how much do we know about this? And as time goes by, we are learning more and more about the GnRh agonist. And so when you look at this paper published recently, they called it the GnRh agonist prediction, assessment, and management. And the reason why it's important is that single-handedly this has been responsible in lowering our ovarian hyperstimulation complications and also making treatment safer, and in the same way helping us to go ahead with a frozen cycle, and that has also given significantly higher success rates, mainly because in highly stimulated ovaries you tend to have a slightly lower chance of pregnancy. So let's go to it. So the agonist is as effective as HCG, and we know that, and the risk of ovarian hyperstimulation is almost eliminated. So if you have a look at the efficacy of GnRh agonist, triggering can be assessed in various ways. One is, in similar ways, you look at the lack of oocytes, that's an empty follicle syndrome, and it seems that the failure rate is between 0.5 to 3.4% of IVF cycles. So what are the means of assessing the efficacy of the agonist triggering? And there are two measures. One is the oocyte recovery rate, and that is a ratio between the total number of oocytes and the number of follicles and the mean diameter of more than 10 millimeter, and oocyte maturation rate, and that's a ratio of between number of mature oocytes and number of oocytes. So if you look at the recovery rate as well as the oocyte maturation rate, and that's the way you assess whether the agonist trigger is working. So let's look at the background and say, what would you look at and suspect and say that these are the women in which the trigger may not work? One is a high or a low BMI, or a long-term recent use of the oral contraceptive pill. And again, PCOS is not a cause. So if you see a low baseline LH and FSH, and that often will be an inadequate response, and you're more likely to be able to see failure of the trigger, and there is evidence that the LH is less than 0.1, then the risk of a suboptimal response, that's the risk of not having a good trigger, is 42.5.2%, while if the LH goes up to around 5, then the risk is about 13.6%. So the low basal LH rate is correlated with suboptimal response, and this again is upcoming evidence, at present still low. So the second question we ask is, does the type of stimulation protocol affect the GnRh triggering efficacy? And at present, we do not think that the stimulation protocol does not seem to influence the efficacy. So what is the optimal dose of triggering? Again, there's no difference between using triptorelin between 0.1 to 0.4 milligram, and no difference using leuprolide 2 milligram or 4 milligram. And at present, there is no preferred agent. So which stimulation variables, and again the question asked is, which stimulation variables and trigger characteristics are associated with a lower response, a poor response? The longer stimulation and higher dose of gonadotropin. So if your dose exceeded 3,800 international units, the gonadotropin failure was around 5%, and if your dose was lower, then again the less than 3,800, then the risk of having a poor response to gonadotropin trigger was 1.4%. The LH on a day of trigger, if it was undetectable, then there's a 25% chance of not getting any eggs. If the LH was about 0.5 on the day of trigger, again remember it's not after, it's on the day of trigger, there's a risk of reduced or suboptimal response varies from 5.2 to 0.2%. Again, the evidence of using the peak estradiol levels is very conflicting, and I don't think we've got a clear idea. And there is some evidence to suggest that lower estrogen levels may give a higher risk of suboptimal response. But again, you have to base it on looking at all this data where the evidence is still low. So what is the ideal time? And this paper was beautiful in terms of it looked at all the collected data and looked at what we would be learning from here. So what's the ideal time interval between the agonist administration, antagonist administration, and the triggering? So what do we believe? We believe that you should not give them close to each other. And remember, there's been a paper which looked at this and said that it doesn't seem to matter. So this study also looking at the antagonist occupying the pituitary GnRh receptors by competitive inhibition. Common practice to maintain a minimum time interval between the last antagonist and the agonist so that the antagonist molecules can be displaced by the agonist. And that is what we normally believe. So we say give the antagonist in the morning and the agonist trigger in the evening. So Horowitz looked at the intervals of more than 2.5 hours and less than 7 hours, and there was no correlation. Again, this evidence is low, and I personally believe, like many people do, that they seem to use a different pathway. The trigger uses a completely different pathway, and I don't think we yet know about it. So is there any role of repeating the dose of the trigger? So sometimes it's my habit to give 2 triggers, basically because we get a large volume, so I split it up and give it as 2 triggers. And there have been 2 RCTs, and it looked at PCOS, 0.2 triptorelin, 35 hours prior to oocyte retrieval versus 0.2 milligram triptorelin addition of 0.3 dose 12 hours later. Again, not significant, but slightly more number of M2 oocytes. There was a second study which says that there were less mature oocytes. Again, conflicting data, and the evidence is quite moderate here. So again, the question comes is, does dual triggering help? Now, there are 2 concepts here. One is dual triggering and double triggering. Double triggering is when you use it as in cases of PCOS where you want to use HCG, and you combine, use the analog trigger. On a day of ovum pickup, you give HCG of 1,500, and that seems to lower the chance of OHSS, but also allowed you to do a fresh transfer. I'm not talking about that at present. I'm talking about giving both together. And again, here the quality of evidence is low, and several authors have shown a higher metaphase 2 oocytes, fertilization, and pregnancies. And the addition of reduced dose of HCG to analog has been suggested to improve efficacy. Again, in women with suboptimal response, of whom 198 were triggered with GnRh analog and 3 different doses of HCG, the dual doses had a slightly higher oocytes, but there were no differences in HCG, so the dose of HCG did not seem to matter. Another study where they were triggered with 3,300 of HCG or 10,000 with dual trigger with the analog as well as 1,500 HCG. The dual trigger gave a higher number of mature eggs, though live birth rate was similar. And again, they have been used in cases where there's been a poorer fertilization with HCG or dual trigger, and that gives significantly higher number of mature eggs. Now, the Griffin looked at the trigger plus HCG and found that the live birth rates were higher. So if you look at it, the data is quite split. There seems to be a role of a dual trigger, maybe in poor responders, maybe in some cases where you see a poorer fertilization, and I think there seems to be a reasonable role. Now, the next step we come to is post-trigger, and I'll say if you can try and do the post-trigger, because it's incredibly important, because it helps you to understand how this treatment is going. So initially they started studying 12 hours after LH surge, and there was no correlation. The clearer correlation was there when you did the blood test of LH 12 hours later. And one study suggested that if the LH was less than 15, the risk of having an empty follicle syndrome was as high as 18.8%. And there were 3 independent groups where it showed that if your LH was more than 15, there was increased number of mature oocytes. If the LH was less than 15, it demonstrated about 2.7% chance of having no eggs. The second thing is, and this is where I think this is my theory, and I think that if your progesterone post-trigger is high, it reflects your granular cell luteinization and tells you more about mature eggs. One of our studies has not proved it, but maybe there's an option of seeing where this goes. So 3 studies noted a higher progesterone level in optimal responders. Progesterone levels reflect degree of luteinization of follicles in response to the trigger, and this may vary. So the higher the number of follicles, the higher the estrogen. Remember, the corpus lutea are more, and there's a higher progesterone. Again, there's no threshold at which progesterone. I've seen progesterones go up till 200, phenomenal, and you start worrying. You think there's going to be ovulation, but that's the number of corpus lutea present. And again, this is based on low evidence. Can suboptimal response to analog trigger be corrected? Re-triggering due to lack of LH rise. There are low numbers again, and all the evidence at present is that re-triggering with HCG seems to work better. So if you have a look at this, where again, if you see very few cases re-triggering with analog, but wherever you re-triggered with HCG, there has seemed to be a slightly better response. But remember that you'll be risking ovarian hyperstimulation. So what did they suggest as the suggested protocol? And I think it is quite reasonable to use this protocol. If you're before you start, if you have a baseline low LH, think about hypog, and there's a risk that you may not see a good response. On the triggering day, if you have a low LH, consider dual triggering, but again, this is risky. If your 12-hour trigger is less than 15, either collect eggs from one side or re-trigger with HCG, but that's a risk because there'll be you will miss some cases who will continue to have mature eggs even with a suboptimal LH. So remember that's quite important. If the LH is more than 15, proceed towards egg collection. If you don't get any oocytes on one side, stop the treatment, and I think re-trigger. That's what we all do. But my caution, and from my personal experience, is even if your LH 12 hours later is less than 15, proceed with egg collection. Only if it's less than 1 or where you know that there's no response, I think it's safe to re-trigger. But you have a 5 to 10 or 12, I think look at your progesterone. If the progesterone is slightly high, go ahead and collect the eggs, at least on one side. So it's a beautiful, comprehensive paper. It covers all the aspects that we at present want to know, but equally you have to understand that the evidence is low. We are learning at present, and I think as time goes by, we will get more and more information. And thank you.